Welcome to Rheumatology Board Review Part 1. I'm Jörg Ehrman. I'm a rheumatologist at Brigham and Women's Hospital and instructor in medicine at Harvard Medical School. And I'm going to go over a few questions relevant to rheumatology. These are my disclosures. And this is question number 1. A 38-year-old woman with a recent diagnosis of seropositive rheumatoid arthritis has been treated with oral methotrexate 12.5 milligrams weekly for the past 4 months. She has had only modest improvement. According to your notes, the number of swollen joints has dropped from 15 to 11, and the number of tender joints has dropped from 18 to 13. Laboratory, she is positive for rheumatoid factor and anti-CCP. Her hematocrit is 36.1. ESR and CRP are elevated. What would you recommend? A, add a TNF inhibitor. B, begin rituximab infusions. C, switch from methotrexate to tofacitinib. D, increase methotrexate to 25 milligrams weekly. Or E, add prednisone 20 milligrams daily. And the correct answer is D, increase methotrexate to 25 milligrams weekly. Fortunately, we have now a number of treatment options for rheumatoid arthritis. Typically, first-line treatment is with methotrexate. And if the patient continues to remain symptomatic on this treatment, then another agent is added. Methotrexate is dosed typically with 15 to 25 milligrams weekly, either orally or subcutaneously. In addition to methotrexate, we give folic acid to reduce the risk for side effects. And when having patients on methotrexate, it is important that cell counts, liver function tests, and kidney function are monitored every 1 to 2 months. Treatment options beyond methotrexate include a number of agents. And these agents fall into different categories. Most of them are biologics, antibodies, or other biologics that target TNF or interleukin-6, antibodies that deplete B cells, co-stimulatory blockers, and then there are also oral small molecules that target signaling molecules downstream of cytokine receptors, specifically here the oral JAK inhibitors that are available as treatment options. TNF inhibitors were the first of these agents to become available, and we have experience for almost 20 years, and therefore TNF inhibitors are often the first choice when an agent needs to be added to methotrexate. The fifth option in the clinical vignette were corticosteroids. Corticosteroids are effective in treating the inflammatory symptoms and signs of rheumatoid arthritis, and they may be useful as adjuncts when used at low doses. However, corticosteroids are not a good long-term treatment options because of the many side effects associated with these drugs. Question number 2. Since the introduction of monoclonal antibodies into clinical practice about 20 years ago, biologics have revolutionized the care of patients with rheumatic diseases, cancer, and other illnesses. Within the next few years, the patents of several of the original biologics will expire, opening the market to biosimilars produced by competing manufacturers. Which of the following statement regarding biosimilars is correct? Compared with the reference product, biosimilars, A, are structurally identical, B, have similar efficacy, C, are about 90% cheaper, D, are cheaper but may not be as effective, or E, all of the above? And the correct answer is B. They have similar efficacy. In contrast to the generic drugs of small molecules, biosimilars are not structurally identical. Biosimilars are proteins, antibodies or recombinant proteins. And so they have an amino acid sequence, and they have the same amino acid sequence as the reference compound. However, their ultimate three-dimensional structure may differ slightly because of post-translational modifications that are introduced in the production process of these biomolecules. So biosimilars are not structurally identical in that sense. They are different from generic drugs. However, they are highly similar to the originator molecule, in particular with regard to clinical efficacy and safety. Current policy is that biosimilars need to show equivalent efficacy in at least one clinical trial in one indication in order to obtain approval. And then approval will be extrapolated to the other indications for the originator molecule. Question number 3. A 52-year-old female with seropositive rheumatoid arthritis comes for her annual physical examination. She was diagnosed with the disease 10 years ago and is currently taking 20 milligrams of methotrexate weekly and injects a TNF inhibitor every other week. She denies any significant joint problems, such as joint swelling, pain, or morning stiffness, and feels generally well. She plans to travel to South America later in the year. You review her vaccination records. Which of the following vaccines should be avoided in this patient? A, hepatitis A, B, hepatitis B, C, TD booster, D, yellow fever, or E, the recombinant zoster vaccine. And the correct answer is D, yellow fever. This question tests or emphasizes that certain types of vaccines are contraindicated in patients on immunosuppressive drugs. And these are any type of live vaccines. Out of the choices in the clinical vignette, only yellow fever is a live vaccine and should therefore be avoided. There are two types of zoster vaccines that are available. The newer recombinant zoster vaccine is safe in patients on biologics or other immunosuppressive drugs, and in fact is recommended. Generally, all patients on immunosuppressive drugs should receive their annual flu shot, and they should also be vaccinated against pneumococci, ideally prior to the initiation of immunosuppression for optimal protection. Question number 4. A 28-year-old kindergarten teacher presents with 1 week of pain, swelling, and morning stiffness in her hands and knees. 3 weeks ago, she had a cold with nasal discharge, fever, malaise, and muscle aches. Several children in her class had similar symptoms, accompanied by an erythematous rash on the cheeks. On exam, there is mild soft tissue swelling of several PIP and MCP joints. She also has minimally swollen and tender wrists and knees bilaterally. CBC is unremarkable, ESR is slightly elevated. She has an ANA of 1 in 40 and a rheumatoid factor of 24 units, which is slightly positive. The question is, what initial treatment would you recommend? A, naproxen 500 milligrams twice daily. B, hydroxychloroquine 400 milligrams daily. C, methotrexate 15 milligrams every week, plus folic acid 1 milligram daily, D, prednisone 20 milligrams daily, or E, doxycycline 100 milligrams twice daily for 1 week. And the correct answer is A, naproxen 500 milligrams twice daily. So this question offers several treatment options for various types of arthritis. Naproxen here is the only non-steroidal and is the appropriate therapy because the patient in all likelihood has a viral arthritis. If we go back to the question, so this is an acute presentation of a symmetric polyarthritis, not very different compared to rheumatoid arthritis, but it is an acute presentation, and there are other elements in the history that suggest that it involves a virus. In this particular case, the most likely scenario is that the patient has been infected with parvovirus B19, which causes fifth disease in children. And infection with this virus may result in an acute mild symmetric synovitis. And this is what the patient in all likelihood has. The treatment is with non-steroidals, and typically the arthritis symptoms resolve over time. In patients with viral-induced arthritis, the rheumatoid factor may be mildly elevated. The ANA of 1 in 40 is borderline and not considered to be significant. Question number 5. A 25-year-old female medical student presents to the emergency room with chills and a diffuse rash and fever. This started the day after she returned from Haiti, where she had spent 1 month volunteering in a health clinic. Within hours, she also developed severe widespread joint pain affecting her PIPs, MCPs, wrists, MTPs, ankles, knees, and hips. On exam, she has a high fever, she's tachycardic, she has a diffuse blanchable erythematous rash on trunk and limbs, and she has several swollen MCPs and MTPs, and in addition, several tender joints. Laboratory shows an anemia, and the CRP is elevated. Which of these viruses could be the cause for the patient's symptoms? A, Zika, B, chikungunya, C, Borrelia, D, Onyongyong, or E, Ross River? And the correct answer is B, chikungunya. Obviously, C is incorrect here because Borrelia is a spirochete, a bacterium, and not a virus. Out of the other options, chikungunya, Onyongyong, and Ross River are all arboviruses that have been linked to the development of arthritis. However, the distribution of these viruses in the world is different, and only chikungunya chikungunya is the best option here because chikungunya can be found in the Caribbean, whereas Onyongyong is found in East Africa and Ross River virus in Australia. These virally induced diseases are characterized by fever, rash, and an acute arthritis. The infection can be confirmed with antibody testing, and treatment is symptomatic with non-steroidals, and symptoms and signs of arthritis typically resolve with time. This map here shows how chikungunya moved into the Caribbean. So in earlier decades in the 20th century, the virus was found in Africa, later also in Southeast Asia. And in the last decade, the virus moved to the Caribbean, and cases of chikungunya-induced arthritis have been reported from there, but also in travelers returning from this region to the United States. Question number 6. A 72-year-old female presents with 6 weeks of stiffness in the neck and both shoulders. She has shoulder pain when dressing herself in the morning. She also reports pain at night and sleeps poorly. Symptoms improve as the day progresses, but then return in the early evening. No significant past medical history except for hypertension. On exam, there is mildly decreased passive range of motion in the shoulders. There are mild osteoarthritis changes in the hands, but no synovitis, and there's no muscle weakness. Laboratory ESR is normal, and the CBC is unremarkable. And the question is, what is the most likely diagnosis? A, polymyositis. B, early rheumatoid arthritis. C, fibromyalgia. D, polymyalgia rheumatica. Or E, metabolic myopathy. The correct answer is D, polymyalgia rheumatica. So why is that the correct answer? The patient reports stiffness and pain in, if we go back, stiffness and pain in the neck and shoulders. She does not have any evidence for muscle weakness, which makes polymyositis and a metabolic myopathy unlikely. There's also no evidence for synovitis on exam, which makes rheumatoid arthritis much less likely. And she does not report diffuse symptoms, pain all over, which would be characteristically seen in a patient with fibromyalgia. So the most likely diagnosis here is indeed polymyalgia rheumatica. Now, you may have expected that a patient with PMR should have an elevated ESR. However, it has been shown that in a number of patients, up to 20% ESR or CRP can actually be within normal limits, although typically these markers of inflammation are elevated. Just as a reminder, PMR is not infrequently associated with GCA, so it is important to ask about headaches, visual loss, jaw claudication, and fever. Question number 7. An 80-year-old woman was hospitalized 2 days ago for upper GI bleeding. She was found to have a peptic ulcer and was placed on omeprazole plus IV normal saline for hydration. Today, she presents with acute painful swelling of the right knee. The past medical history is significant for osteoarthritis of the hands and knees, for which she took ibuprofen at home. On exam, she is febrile. There are Haberden and Bouchard nodes in both hands, and there's a warm and large effusion in the right knee. The knee aspiration yields 60 milliliters of yellow cloudy fluid, and the examination of this fluid is positive for intracellular rhomboid, positively birefringent crystals. And now the question is, what is the likely cell count in the synovial fluid of this patient? A, 500 cells per microliter. B, 500 cells per milliliter. C, 15,000 cells per microliter. D, 15,000 cells per deciliter. Or E, 15,000 cells per milliliter. And the correct answer is C. The most likely cell count in the synovial fluid of this patient is 15,000 cells per microliter. If you got this wrong, You are probably not alone. In fact, many rheumatology fellows will get this question wrong because they don't know the correct unit. So this question tests two different aspects. Number one, when analyzing synovial fluid, we are interested in how many inflammatory cells are present. And the cutoff between non-inflammatory and inflammatory synovial fluids is 2,000 cells per microliter. And so that already tells you that the unit here is important. So 15,000 cells per microliter is clearly inflammatory, and that is also the correct unit. This is admittedly a bit of a pet peeve of mine, but units are important. For instance, CRP in some hospitals is measured as milligrams per deciliter. In other hospitals is measured as milligrams per liter. And without knowing what the correct unit is, the interpretation of data, for instance, from a patient who was previously seen in a different institution, can be incorrect. So just for review, these are the types of information we are looking for in a synovial fluid analysis. So we look for cell cut and differential, gram stain and culture, and crystals. Not informative in synovial fluid are albumin, protein, or glucose levels. And again, the inflammatory cell count is characterized by more than 2,000 cells per microliter. The higher the cell count in the synovial fluid, the more likely is a septic joint, and correspondingly, a high neutrophil fraction, more than 95%, makes a septic process more likely. Question number 8. What is the serum uric acid target for patients on uric acid lowering drugs? A, less than 4 milligrams per deciliter. B, less than 5 milligrams per deciliter. C, less than 6 milligrams per deciliter. D, less than 7 milligrams per deciliter. Or E, less than 8 milligrams per deciliter. The correct answer is C, less than 6 milligrams per deciliter. The most commonly used drug to lower the serum uric acid level is allopurinol. I want to emphasize that the correct use of this medication and other uric acid lowering drugs is to treat the patient to target. So it is important to achieve the appropriate target level, which is 6 milligrams per deciliter in all patients. In some patients with severe gout or a high load of tophaceous material, one can also aim for less than 5 milligrams per deciliter, which may result in faster dissolution of crystals. When starting patients on uric acid lowering drugs, it is important to give anti-inflammatory drugs, for instance, low-dose colchicine, as flare prophylaxis. Allopurinol is typically started at 100 milligrams per day, and at this low dose, the risk for potential side effects is reduced. But many patients may also require doses higher than 300 milligrams per day in order to achieve their target serum uric acid level. I typically repeat the serum uric acid test 1 month after dose adjustment before deciding on the need for further dose adjustments. Allopurinol toxicity can be a range of things. Rashes are not uncommon, LFT abnormalities, and then rarer is allopurinol hypersensitivity syndrome. Again, starting patients on lower doses reduces the risk for toxicity. In patients of Southeast Asian descent and African Americans, it is recommended to screen them for HLA-B 5801, which is associated with a higher risk for side effects. Alternatives in patients with allopurinol toxicity are desensitization, if it's just a rash, but then other medications include febuxostat as another uricostatic drug, and then uricosuric medications as well. Question number 9. An 84-year-old male without significant past medical history presents with fatigue and malaise for 6 weeks. He tires easily and has difficulties completing routine daily activities. He reports a 4-pound weight loss. Review of systems is negative for fever, night sweats, shortness of breath, chest pain, changes in urinary or bowel habits. He denies joint pain, stiffness, headaches, or visual complaints. On exam, he is looking tired, but otherwise unremarkable. And laboratory demonstrates an anemia with a hematocrit of 28.4, and the ESR is 120. What would you do next? A, perform a biopsy of a single temporal artery. B, perform a biopsy of both temporal arteries. C, start the patient on a trial of prednisone 60 milligrams daily. D, start a prednisone trial of 15 milligrams daily. Or C, order a serum protein electrophoresis. And the correct answer is E, order serum protein electrophoresis. Clearly, the correct answer here depends on the working diagnosis based on the clinical vignette. Options A, B, and C would be appropriate for a working diagnosis of giant cell arteritis, whereas D is an answer that would be correct in the context of a patient with PMR. However, what are the pertinent pieces of information in this patient here? So he has a normocytic, he has an anemia and a very high ESR. He reports fatigue, but not stiffness. He has no headaches or visual changes and a largely normal physical examination. So certain features of that one would expect in PMR and GCA are missing from this vignette. So in this patient with a very high ESR, the next step would be to rule out a dysproteinemia and myeloma, and that would be the first thing to do before starting the patient on empirical corticosteroids. Question number 10. A 42-year-old man is evaluated for pain and swelling of his left wrist. This started suddenly 4 days ago. He has no history of trauma. The patient has insurance through HMO Cheap. In addition to radiographs, they will only pay for one single blood test. And here you see the X-ray of this patient, and I've highlighted a few critical findings with red arrows. So which of the following tests should be ordered? A, transferrin saturation. B, serum calcium. C, rheumatoid factor. D, anti-nuclear antibody. Or E, serum uric acid. And the correct answer is A, transferrin saturation. The pertinent pieces of information in the clinical vignette here are that the patient has chondrocalcinosis. He presents with an acute arthritis in the wrist, similar to gout, but in this context here, because of the chondrocalcinosis, more likely due to pseudogout. And moreover, he has degenerative changes in the wrist and also the MCP 2 and 3 joints. I'll go quickly back to the radiographs, where on the left here you see joint space narrowing, and there is calcification here in the wrist. And then this is the MCP2 joint, where there is clear cartilage loss. So this is a patient with CPBD arthritis related to calcium pyrophosphate dehydrate disease with the development of secondary osteoarthritis in the MCP joints. There's a number of conditions that are associated with this. Probably the most likely one, and the only one that was an option in this question here, is hemochromatosis. And therefore, the correct answer is to check the transferrin saturation. Even though there is calcification in the tissue, serum calcium measurements have no role here. And the patient clinically does not seem to have rheumatoid arthritis or lupus, and the serum uric acid level would not be the first test to get if there's only one as an option, because of the findings suggesting pseudo-gout. And this is the end of part 1 of the Rheumatology board review.